I'm Georgia Turasi. I'm the director of the Health Data Sciences Institute at the Oak Ridge National Laboratory.
I'm John Lott. I'm the Senior Director for the Regional Forensic Center in Knox County, Tennessee.
I'm Blair Christian. I'm a research scientist at the Oak Ridge National Laboratory.
I'm Dr. James Choo. I'm Medical Director at Pain Consultants of East Tennessee in Knoxville.
And I'm Karen Pershing with the Metro Drug Coalition in Knoxville.
Well, thanks to our friends from Knoxville for joining us. All right, you may proceed.
So we have a presentation.
Okay.
Mr. Chairman, members of the task force, thank you very much for the opportunity to share with your vision of how strategic stakeholder partnerships, when coupled with supercomputing, can really unlock the potential of big data and help address the opioid epidemic in Tennessee and the nation. As you've heard, we are a multidisciplinary panel here. We bring a variety of expertise, and this is an exercise, a brainstorming exercise that has been going on for quite some time among all of us, what we can bring to the table to help with this epidemic. So very simply put, when we bring together big data and big computers, we can really deploy very important and new advanced analytics technologies, such as artificial intelligence, to make the most of the big data and develop really cost-effective, proactive approaches to health crises, which is very different from the dull, reactive response that we're accustomed to. Now, with that mind frame, the Department of Energy in the past year has established two very important partnerships. One with the National Cancer Institute and the other with the Department of Veterans Affairs. Both partnerships exemplify the use of supercomputing to advance cancer research in one case and to advance precision medicine in the second case. The Oak Ridge National Laboratory, as you know, is home to the nation's largest supercomputer. Therefore, we play a leading role in both partnerships, the Health Data Sciences Institute and some of the members you see here. So let me go over a little bit the two partnerships to help you understand the scope. The first one, the partnership with the National Cancer Institute, the emphasis there is on advancing precision oncology. What the Oak Ridge National Lab is doing for this effort is to develop informatics tools and solutions to enable a cost-effective and performance-scalable national cancer surveillance program. With the second effort, the partnership with the Veterans Affairs, the emphasis here is on precision medicine. Emphasis is on analysis of clinical and genomic data that come from the Million Veteran Program to improve the lives and well-being of the veterans of our nation. Both activities are directly aligned with the broad objectives and vision of the 21st Century Cures Act. Furthermore, what is very interesting and important with both activities are the challenges, the healthcare challenges that are presented to the Department of Energy serve as drivers for advancing the exascale computing initiative the Department of Energy leads for the nation. So to summarize, beyond the leading computing infrastructure and the leading data science expertise that exist at the Oak Ridge National Lab, there are some unique contributions that ORNL brings to the table. First of all, we have the ability to handle and secure patient health data. We have this capability. Second, we have extensive experience serving as a neutral entity, facilitating the complex interactions and collaborations among different stakeholders that these national level initiatives require. Third, that speaks closer to our scientific thinking, we regularly pursue science to solutions approaches. Driven by the application, we care about disease-agnostic solutions that could be extensible in other problems beyond cancer and precision medicine. And last, our long-term vision is to deliver for the nation a computational modeling infrastructure that will be able to support precision medicine advances as well as careful exploration and decision-making and guidance for population-level health challenges. Thank you.
Good morning, Chairman. I'm here representing the Knox County Drug Overdose Task Force, whose membership includes the Knox County District Attorney's Office, the Knox County Regional Forensic Center, Knox County Sheriff's Office, Knoxville Police Department, the Appalachia HIDA, High Intensity Drug Trafficking Area, and the DEA. We're a recently formed group that was built off of trying to address the drug issues and the drug overdose deaths that are occurring in Knox County. We recently received a grant from the Appalachia HIDA, which is a federal grant, which will help us focus on those issues within our county related to drug-related deaths, as well as drug-related law enforcement issues. The law enforcement agencies, the District Attorney's Office, and the Regional Forensic Center have each been tracking drug use and drug deaths over the past 6 years. We see a steady increase in that. Recently, the Regional Forensic Center produced a report. In that report, what we saw was that 75% of the drug deaths over the past 6 years have been related to prescription drugs. One of the issues that we see combined with prescription drug use is the fact that as drugs are emerging, they're changing just a little bit here and there, and so the analytes change just slightly. There are a couple of bills that are being proposed now, House Bill 0337 and Senate Bill 0192, which begin to address some of those issues, but I believe there may be an amendment that's needed for that in order to account for new and emerging. Those two bills really seek to identify U47700, and that's a drug that the Regional Forensic Center in Knoxville found in May of 2015. The problem with that was the drug company that was doing the test for us could not analyze it and detect it until about 6 months later. So new and emerging drugs are happening all the time. The problem is it's very difficult to detect, as well as it's hard for law enforcement to try to take action against it because it's not on the schedule of drugs. As you can tell, our goals are relatively simple here. We want to identify and prosecute street-level sources of illegal opiates and other drugs. We want to lower the drug-related deaths and overdoses and arrests that occur in our area. We want to develop the best practices and a uniform data collection tool for regional use. We want to also create a confidential and secure, behind the task force firewall, database in order to house the sensitive information from both law enforcement and from the medical side. We also want to, from that, quantify and analyze the data and then present de-identified data and reports to our partners so that they can take action. By working as a close-knit task force, we're able to quickly identify and take action on these cases where oftentimes data and information would be lost. So as we see these cases are popping up, we talk among ourselves to make that happen in a very timely fashion. We believe that as we develop our best practices, we'll be able to provide other groups such as ourselves, medical professionals, and the community with guidelines and data to assist them in meeting their goals. And of course, we're working to develop a database of case information that will be able to provide these reports to our partners so that they can take action on drug overdose issues. As with all endeavors, there's opportunities and challenge. For the Knox County Drug Overdose Task Force, we've begun to develop our working relationships. As we've done this, we're identifying that there's data-related challenges. We're compiling a large amount of data from multiple agencies and sources, such as arrest reports, cell phone records, autopsy reports, toxicology reports, prescription drug histories, and subpoenaed records. It is important that we understand that these issues bring with them some sensitive related data. Of course, we understand that we have a responsibility to guard that information, but we also have a responsibility to work with other groups to de-identify that data, bring it forward in reports as well as a mega data set so that they can use that to take action on their side. In the future, we do plan on partnering with ORNL as well as other groups to help us do that. We do see that the task force mission is not only to go after the street level dealers and to help reduce these issues, but we see our mission as working with groups such as ORNL to make that happen. In conclusion, the Knox County Drug Overdose Task Force, my partners here, and I greatly appreciate your time on this issue. We look forward to working with you to develop positive actions in the future to address these issues. I'll be followed by Dr. Choo.
Thank you.
Chairman, members of the task force, thank you very much for allowing me to speak today. I think John Lott and his group, his task force, represent an opportunity for a particular set of stakeholders to look at the opioid problems in their lens from the law enforcement and criminal end. And maybe the supercomputer can help kind of shape how they do their business. In my particular case, in Karen Pershing's case, we're looking at this from a different angle. For me as a provider, the supercomputer may be helpful in the future in helping me figure out who are these individuals that are more likely to go down this road of addiction, death, neonatal abstinence syndrome. Okay, and so was there something in the timeline, in the course of treatment that pushed them along in a good way or a bad way? Those are big questions that as a provider, we have zero understanding or very little understanding. We can surmise, we can guess. But data may be able to help create a clearer picture for us. And so that we have less folks going down the wrong road, providing better options in the future to steer them in a better direction. When it comes to big data, can big data help us with neonatal abstinence syndrome and overdoses? And I'm going to pass this on to Karen to have her speak on her perspective.
Thank you, Mr. Chairman and members of the committee. I look at this as a huge opportunity to really be able to go upstream of this issue, whether it be overdose deaths, whether it be neonatal abstinence syndrome, or just pure prevention to begin with. I think we can stop the flow of this problem if we've got some data that can point us in the right direction. So if we can identify who are the at-risk women who are most likely to deliver a neonatal abstinence syndrome baby, can we identify them? Can we educate them? Can we get long-acting reversible contraception to them to really prevent neonatal abstinence syndrome to begin with? As far as addiction goes, again, can we go upstream? Can we target certain areas of our community by using this data and know which pockets in our community are the most at risk and target our resources, our very limited prevention resources, in those directions? So we're really excited about the potential and the possibility of sharing data and putting all that data together to really create some risk models that we can take and apply to various pieces and parts of this particular epidemic.
Some concluding thoughts before we move on to questions and answers. we see this as a potential opportunity, a huge opportunity for the state of Tennessee. A partnership we hope that the state of Tennessee can develop within the national laboratory. When you think about the national laboratory and its culture and its history, you think about it's the national laboratory's involvement in the nuclear age, okay, as a transformative scientific revolution for the entire world, okay. Also, if you think about the national laboratory, you're thinking about the Human Genome Project and its integral role in developing the human and mapping out the human genome. The National Laboratory was integral in those respects. Now, when it comes to data-driven discoveries, all right, this is the Department of Energy has put their dollars and cents into this next step, this next revolution, and its applications to big, large-scale societal problems, okay, health-related problems, okay. And so they've made efforts with the National Cancer Institute, Veterans Administration. What better way to actually use their analytical powers and their resources to look at the opioid epidemic, and letting the data help us drive and discover where resources should be placed, prioritize them in scientific ways. And also, if we look at the impact of the opioid epidemic to the state itself, this is a problem that costs us millions and millions of dollars. All right, and there's a lot of information, a lot of stakeholders with a lot of data, but it really takes something like the supercomputer to be able to best analyze the information and then prioritize resources in a scientific way, in ways that are groundbreaking scientifically and world-leading capabilities and analytics. And I think there's an amazing opportunity here for that. So there may be some legislative challenges, as you can imagine, that are unforeseen in being able to analyze some of this information. We'd ask that the task force take a look at this seriously if those challenges arise in the future to help with breaking down some of those barriers to get into some of the data silos. But with Representative Dunn's help, we are also trying to have a workshop at Oak Ridge National Laboratories. And we invite all members of the task force to take a look at the computer. I think there's maybe some interest at the executive levels of the government as well. And we would like to be able to invite you all to see more up close what this could potentially do for the state.
Thank you. Do I have questions? Chairman Lamberth.
Thank you, Chairman. I was just curious if it sounds like this is still a pretty recent kind of effort, I'll say, with you all putting your heads together and utilizing the technology that's out there. At this point, have you been able to see any definitive results, or are you still in kind of the beginning stages? And I know you referenced a couple of things in your presentation, but it seemed like my impression that I'm getting is that this is still a very recent endeavor, is that it's just a little too early to say, hey, here's the results we're seeing from this. Or am I wrong on that? Are there already some results that you're seeing?
You're absolutely right. We are still in the initial stages because the first hurdle is access to the right data. And the different data sets that are important for this endeavor sits in different silos. A similar challenge that exists with the NCI efforts that we have and with the VA. So part of this presentation, and for all of us coming together, we want to galvanize the community to understand the importance, what is possible, and what are the initial bottlenecks that we all need to address collectively. The workshop that is organized at the Oak Ridge National Lab is exactly for that, to bring the different stakeholders together to develop a roadmap that will lead us faster to results.
Chairman Lamberth.
It was kind of the impression I was getting. I just wanted to make sure that there wasn't anything that you're able to kind of pull out of any data that's out there now. So basically, this is at this point just a concept where you're saying if we were to do this, you feel like it would be beneficial, correct? Thank you.
Chairman Calfee.
Thank you, Mr. Chairman. I don't have a question. I just have a comment. Thank you all so much for coming. I retired from the lab at end of 2011, and rather than going in retirement, I did this. And so I know a lot about what goes on at the lab. My wife's the chairman of the board of the Anti-Drug Coalition in Roane County, and we have several friends who have adopted drug-addicted babies, and they're just saints in my eyes. And thank you so much for being here and explaining things to the committee. Thank you again.
Chairman Dunn.
Thank you, Mr. Chairman. First, I need to thank everybody here. I've interfaced with them for long periods of time, and most of the good legislation we've had come out of here is because of folks like that who've worked together to come up with it. I know in your presentations a lot was talking about the patients or those who are abusing the drugs or addicted to the drugs. And I really think we need to go the step before that is to get data from the medical community, because if we can find in the data which doctors are most likely to overprescribe, give a 30-day supply when a 2-day supply is enough, if we can fix that, it really helps with the addiction and who's getting abused and stuff. So I hope that would be part of the equation. And I think what I'm hearing you say is, if they were just analyzing state driver's license data, it'd be real easy to go and get that one, I think you used the word silo. But when it comes to healthcare and the data, there are so many different groups. And what we can do to help is make sure that they can get access to those different state data pools, wherever they may be, because when they put them all together, that's where we get the good results. And one thing we had talked about, and I think this is a concrete thing this committee can do, is the new head of the Department of Energy is former Governor Rick Perry. And so part of his responsibility is to the Oak Ridge National Lab. Correct me if I'm wrong on that. And so I think it would be very appropriate that, since this is, we're talking about Tennessee here, but it's a problem that's national. And I think we need to get it on his radar. So as he's looking at the budget for the whole Department of Energy, he would say this is a good place for resources, because what we can discover here in Tennessee and Oak Ridge by taking all this data can be used nationally. So he's a former governor, and I know we have a current governor who's probably interfaced with him sometimes, so maybe we can get him. Maybe he's got his cell phone number or something. But that's something we could work on that. And in the paper that they shared with us, I think something that jumped out at me was Oak Ridge National Lab is certified to host and analyze protected health information. And that is so important, because we all know with HIPAA and all that you just can't take data and give it to anybody. So they are set up to help us find the solution, and I hope we take advantage of it. Thank you for what you all do.
Senator Representative Dunn, just one of the projects that could be quickly established is really with the CSMD data from the Department of Health. It is a very large data set, and ORNL is positioned very well to begin looking at that data set and address the problems that you just brought up, which is which prescribers are prescribing too much. Are they following the Tennessee Code Annotated, which you guys have promulgated, and look at the patient and their prescription pattern before they prescribe an opioid or any other substance. And so there's a project that's ready and waiting, but part of that is getting access to that data.
And the CSND,
it's the Controlled Substance Monitored Database.
And it's through TennCare.
It's the Department of Health,
Okay.
Department of Pharmacy.
And we've actually had a conversation with Commissioner Dreisner earlier in the summer, and some of the leaders of the CSMD, and presented some of the same information that we're presenting to you. And Commissioner Dreisner was very supportive of this type of initiative. And I believe ORNL has spoken with the Department of Health's legal team to work out a memorandum of understanding together. So at least at the Department of Health level, they're aware of this type of work and supportive.
In Knoxville, what type of data are you supplying at the present time?
Currently, the Drug Overdose Task Force has just formed. The issue that we're going to have with our data set is that much of it is law enforcement related, as well as data that will be subpoenaed. So we're looking at how do we de-identify that data so that we can possibly share it with ORNL so that it can be combined with patient data on how they are being treated, as well as other social data sets that they have available.
What about the pharmacists, the data that the pharmacists have on?
That would be the CSMD data.
Okay.
So the pharmacies are obligated to input data anytime controlled substances is dispensed. So some of the leaders of the CSMD are part of the pharmacy board, I believe, if I'm not.
And the prescribers would be included in that also?
The individual, the patient, the prescriber, and the pharmacy itself as well.
Chairman Halford.
Thank you, Mr. Chairman. And again, as everybody else here has said, thank you for being here with us today. This is a very, very important task force that Speaker has charged us with, and we very much take it seriously. We've heard several weeks of testimony from several different people. We've heard much talk about treatment, what happens with treatment. We've heard very, very little about police activities in this. I think it is imperative that information be shared among all of those communities. I think, and I have said this before, that until we have prevention, we are going to always have treatment. So I think it's very, very necessary, and that it's imperative that this information be shared with all the stakeholders here, particularly law enforcement, to try to get our heads wrapped around this. It is such a terrible, terrible problem. So thank you, Mr. Chairman.
Are there any other questions? Chairman Reagan.
Thank you, Mr. Speaker. And I'd like to thank you for being here as well, since Representative Calfee and I share the complex out there. I believe the lab is actually in his district, but the front gate's in mine. Nonetheless, we appreciate you being here and appreciate you offering the facilities that you have available to you, which are unique nationally. And I want to echo some of the other things that have been said here. I have observed, as have a number of other people, that ORNL has a championship position when it comes to identifying problems and coming up with solutions. So I think the challenge is before you, and we will watch with great interest to see how you meet that challenge. Thank you, Mr. Speaker.
Thank you. Chairman Dunn.
Thank you, Mr. Chairman. I think we've talked in generalities, data silos, that sort of thing. At some point, we need a list that we can check off. Here's what we need from the Department of Health. Here's what we need from CSMD. Here's what we need from so-and-so, and what format it's in, that sort of thing. And so we can start having an action plan to say, okay, we'll talk to the Commissioner of Health and see what we can do to help there. And then somebody else might say, well, we'll talk to CMSD. But let's get the list of what you all need to be successful, and then start taking action on each of the items to gather it, and then we can go forward. Is that?
That would be wonderful. We would be happy to do that.
Yeah, if you could get us a list, and of course we're the state, so there's on the federal level we could probably help you there, but.
Yeah, if you would get the list, and then we can divide it up and see who's the best person to find it. But you need to let us know what's in the recipe, okay? And then we'll bake it. Thank you.
Any other questions? Thank you very much, and again, I apologize for making you wait. And if you will get us that list, you have our word that we will take swift action. Thank you so much.
Thank you so much.
Thank you very much.
Thank you. And now it's my great honor to introduce the Comptroller of the great state of Tennessee, the Honorable Justin P. Wilson.
Well, it's been a long, well, let me turn on the light here. Well, it's unfortunate that it's on. I'm Justin P. Wilson. I'm your beloved Comptroller. I will try to be mercifully brief. It's a long day. I'm here to talk about the cost to state government that we've identified in the budget of opiate abuse or use of opiates. And we all know already that opiates are really a very valuable tool for a doctor, designed to alleviate pain on a temporary basis. But sometimes something designed to alleviate pain causes pain, not just to the individual affected, but to all those around him. Let me just give you an example of how opiates can be used, and it's personal. I had a hip operation, and the doctor prescribed opiates, and the nurse gave them to me when I was in the hospital. Doctor gave me a prescription, and my wife took the prescription, and she doled it out appropriately. Well, I'm not sure if everybody is lucky enough to have a doctor for a wife, or maybe unlucky enough. I don't really know. But here I'm here to talk about the cost to the state of opiates. And the cost is a real big number. Now, you folks may know me around here as, before I really start talking about what the cost of opiates in dollars and cents, we really have to recognize that the cost is really in human lives, and where we're dealing with lives that could be damaged and sometimes beyond repair. And how in the world can you calculate the value of a parent, sibling, child, friend, even a newborn baby? And most of you folks know me as your state comptroller, the beloved comptroller, or maybe even the money cop. But around Vanderbilt's intensive care unit for children, I'm known as Barbara's husband. And that's because Barbara she's an associate professor of pediatrics out at Vanderbilt. And she and her colleagues, they deal with NAS babies on a daily basis, up close and personal, down where the rubber meets the road. And these are those kids who enter life dependent on opiates. And caring for these babies is just one of the costs that we'll look at. When you talk about it, there are really two types of broad costs that we consider when talking about opiates. You have the direct cost, and by direct cost, what we're really talking about are costs that we've identified, or the state agencies themselves have identified in their budgets that relates to opiates. And so when we talk about direct costs, we're talking about only those things in the state budget that have been identified as such. We don't consider our direct costs to be what a county would have, would expend on opiates. And of course, all you county commissioners, I'm very sure, realize that these costs are real and sincere. Now, when I say identified, we know that all costs have not been and cannot be identified. I've had a lot of experience dealing with alcoholics, and very few alcoholics that I know, say that admit that they're alcoholics. And our doctors are not all that good in identifying this issue. And the same is true for opiates. So what we're talking about is just a fraction of the total direct costs to state government. Now, here's what direct costs are. You can see it on the board there or here. And about what you expect. And to account these, what we did is we asked for data statistics from the various state agencies. And we talked to TennCare and Mental Health. We talked to Children's Services, Department of Health, F&A. You say, why at F&A? Well, they're the ones who run the state health plan. Corrections, TBI. They gave us a lot of numbers, and we assembled them here for this task force. Let's just start with TennCare. In 2014, the identified costs for NAS babies, that's babies with neonatal absence syndrome, covered by TennCare was a little over $51 million. Now, the average cost per baby was about $48,000 compared to per year for the first year, compared to about $8,000 for other infants. Average hospital stay over 24 days compared to just about 3 days for other babies, other infants. There's about a 19% chance that a child with NAS syndrome ends up in DCS custody, but less than 1% for other infants. So that gives you some idea. Now, the amount of money that they spend on drug treatment costs is about I can't read it over there. $4.6 million, but they don't break that out by drug treatment, but that gives you some idea of the magnitude on opiates. And the MCOs, well, they report spending about $54 million on treatment, and they estimate that 41% of this is for opiates, and that doesn't include heroin. Let's go to mental health. What mental health does is that they have services for low-income Tennesseans who don't have insurance. That's low-income Tennesseans without insurance. And they provide substance abuse treatments. And what they estimate for opiates is about $17 million a year, or $3,000 a person. And the next is doesn't have here you can see exactly where some of the money is spent. Hadn't been able to break it all out, but it gives you a pretty good idea. Now, here's what the real issue here with mental health, though, is that we're talking about the cost for a little fewer than $7,000. And they've identified or believe that there are over 30,000 Tennesseans who are qualified. That means low-income Tennesseans without health insurance that need this treatment. So that treatment's not been provided, and of course, the cost was not included in these numbers. Over at Children's Services, there were about 1,500 children who are in custody as a result of parental drug abuse. And the cost attributable to those with opiate abuse, about $17 million. And they calculated the costs for children that are not in custody but have an open case with Protective Child Services. And that for opiate abuse is about $2.5 million. Department of Health, their most current data shows about $5 million for opiate-related programs. Breakdowns there on the board. Now let's talk about the state health insurance program. That's the insurance program that state employees here, many of you, are associated with opiates. And it doesn't end there. Real big number is special education cost through childhood and also through adolescence. Then you have the public welfare. You have TANF and all those programs. It goes on and on and on. And it goes on often to the next generation. So let's talk about the indirect cost of opiates. There's some examples there, and they really relate primarily to workplace and private health care companies. This is where the real money is, because the ripple effects are lost productivity, and probably more importantly, lost opportunity. Not just to the person affected, the person who's abusing the opiate, but also to everyone who works with him or associates with him: family, friends, communities, co-workers. Now, maybe the way that struck me the most is what I heard talking to some manufacturers here in Tennessee. And I asked them, what are the real problems and difficulties you have about doing business here in Tennessee? And I wasn't quite sure to what to expect, but they told me it was finding qualified workers. And I started to ask exactly what that meant, and they said, really? Workers who could pass a test. And I thought they were talking about a skill test or an aptitude test. No, they were talking about a drug test. Now, so that shows that there's real cost for economic development as well. Now, our office, we really haven't researched the total number of indirect costs, and I'm not sure if we're competent to do that. But we tell you what other folks have done. Now, there's a study for Tennessee back in 2008, that put the cost for all drug abuse at $1.3 billion. Another study, this was in 2011, just dealt with opiate prescription drug abuse, just prescriptions. It was $55 billion. One in 2013, it came up with almost $79 billion. And the last used lost healthcare costs, lost productivity, and cost to the criminal justice system. Now, as I said, we didn't attempt, and we're not competent to deal with the total societal cost. And I want to be real clear about what we did do and what we didn't do. What we really did is we dealt with the identifiable costs by the state agencies of opioid abuse that are found in the state budget. That's all. And we didn't conduct a comprehensive evaluation of what Tennessee's doing to address the problem. We didn't look at best practices. We didn't examine initiatives from other states. And we didn't look at the review estimated returns from different kinds of treatment and preventive programs. But what we have done is we found out that the cost is a real cost. It's a real cost to Tennessee. It's a present cost, and it continues into the future. Be happy to answer any questions. Or more properly, find someone who can answer the question, because I ain't going to know.
Mr. Comptroller, in the cost, say, for TennCare, were those costs, did that take into consideration those individuals that were on TennCare that go to emergency rooms for overdoses? Would that cost? Only
to the extent that it's identified as such, and that's probably a very small percentage of it. This is only identifiable costs that are related to opioid abuse and what's reported to them as such. So we're not even scratching the surface of what the real costs are.
And so your figures on corrections.
Oh, well, it's nothing of what the real number is.
We've got a real problem with the population. A large percentage of the population have hepatitis C.
That's right.
They come in with it.
That's right.
And then we are responsible for taking care of it.
Deal with any of that because it's not all those numbers deal with the treatment programs that exist that are identified as such as treatment for this. That's all it is.
Because in our budget hearings with corrections, the treatment for hepatitis C, if a member of the population has hepatitis C, the drugs to treat hepatitis C are very expensive. So,
oh yes,
I agree. We're just scratching the surface.
Oh, well, I want to be really clear. These numbers are very limited. They do not begin to even affect the cost of the state budget, and they certainly don't even deal with the societal cost.
Right.
And then the human cost in addition.
Chairman Dunn.
Thank you, Mr. Chairman. And we could probably sit here all day and think of things that the different costs. I mean,
it's just
the drug abuse. An addict is always looking for the next fix, and they're needing the money. So all this theft, and so the homeowner who goes out and sees his riding lawnmower is gone. That doesn't show up in these, but it really hits his pocketbook and the aggravation of, okay, now I've got to go get another one and that sort of thing. So the people trying to pay for their fix costs just individual Tennesseans a lot of headache and pocketbook ache. One of the slides you had showed that we've treated about 6,700 people. It cost us $17 million, but then you pointed out that there's 30,000 people who really need the treatment.
Well, no, these are the low-income Tennesseans who do not have health insurance. So a much greater percentage than that. But that's only those people. Oh. And of that class of people, then it's 30,000. It's 30,000 who are not getting treatment because it's not an appropriation.
So the number would actually be, because I figured on the 6,700, 30,000, if all 30,000 got the treatment, it'd be $75 million.
That's right. If to treat at a $3,000 a person to treat those individuals who happen to be low income and don't have health insurance, that's the number we're talking about. Could be $70-80 million. Yes.
And then if you added the people who have insurance, but that is a cost, then it's astronomical.
Exponential.
Yeah.
Chairman Sexton.
Thank you, Mr. Chairman. Thank you, Mr. Comptroller, for being here. Appreciate your presentation. I don't really have a question, but you're absolutely right on the ripple effect. And so, we want to look at what it may cost us to just do addiction. One thing I would point out is this is just for opioid. This isn't even for other addictions. This is just going back in. And so when you look at it as a whole, you're exactly right that this is just a third, a fourth, a half, or whatever it may be of what true addiction is in the state of Tennessee. And when you look at the ripple effect, you look at split families, you have DCS money being spent, as you said, Department of Health Services money being spent for benefits, corrections, teen care. And so as we're looking at these challenges to do, we can continue doing what we do and just spend money in 5 different departments, or we can try to find a solution that will reuse that money to provide help for those individuals. And the last thing I'll say is we can't just focus on the addiction side. You also have to focus on the personal health side, because at the end of the day, they still have health issues that they need help with as they overcome this addiction, and you treat the whole body, because a lot of times, especially with mental health, the problem is they won't seek mental health until they have their physical health taken care of, and then they'll go get help for their mental health. So as we continue going forward, I appreciate what you've done to just kind of outline what this looks like, but for us just to imagine that this is a whole lot bigger ripple effect when you look at all the addictions in the state of Tennessee, with this?
It's truly enormous, and don't get my wife started on this. Yeah.
And I agree, Chairman Sexton. And this wheel has a lot of spokes to it, and we're talking about a lot of different areas. Education and prevention. If we could find a way to keep folks off of or keep them from getting addicted, I think that would be very important also. And Mr. Comptroller, we've heard from a lot of people. We've heard from the Center for Disease Control. We've heard we've got information from the New England Journal of Medicine and the National Institute for Health. And we understand that you can only go by the figures that you get from the departments, and we understand that the departments can only go by the figures that they get.
That's exactly where we are.
Right. But, excuse me, we heard from Gabe Roberts with TennCare, and he identified the opioid affected births, like you referenced, as two costs that threaten TennCare.
Oh, yes. Oh, yes.
And if we don't get a handle on this, I think it's going to absorb a large portion of their budget.
Because
am I correct?
You're absolutely correct. And the numbers I gave you are those that are identified as NAS. And the best we can tell, we can't quantify it, is low weight babies and preterm babies very often have opiate related, and those numbers using interpolation probably are much, much larger. In fact, I suspect they're multiples of the number I gave you.
In your opinion, Mr. Comptroller, if we don't take a serious look at this and attack this issue, in your opinion, what do you think the threat to our state's physical budget, our physical future, will be if we don't get a handle on this?
Well, I think we'll have to make a decision as to whether or not the state assumes a responsibility for the health and well-being of its citizens or not. And it's difficult for me to see us not doing that. But if we do that, then we're either have a real serious financial situation in the state of Tennessee that none of us want to deal with, and almost certainly are looking at substantially, and I mean substantially, multiples of our current rates of taxation. Yes, I do. I think that this, if this continues, I think that I don't want to say our sovereignty, because I'm not sure that may be overstating it. But I think the society as we know it right now would be difficult to maintain.
And you talked about the cost for NAS babies for the first year.
First year, that's
right.
All it is, first year. And it goes on for their entire lives now.
All right, let's talk about our education system. If we talk about K-12 education, in your opinion, the impact that it's going to have on public education?
Don't know. The cost that we have now, we currently incur on account of this for education are not included in any numbers I've given. And we know very well that this is a real cost. I know that my wife is really excited when she sees a baby she treated 7, 8, 9 years ago, and the kid is going to school and having appears to be a normal life. I mean, when she sees this, she feels really good about it. I don't know to what extent that we can continue our current education system, but I'm so far out of my area of competence, I'm very nervous to answer it.
Chairman, you're recognized.
Thank you, Chairman. And of all the testimony, thank you, by the way, beloved Comptroller, of all the testimony that I've heard in the last 6 weeks, we've heard today from scientists and we've heard last week from TennCare, was the week that we heard from the pharmacy organization that talked about how early we've got to start educating even to the middle school level. And I think of all the testimony that I've heard, I think today, beloved Comptroller, you have brought us the end result. If we don't, then we shall. But I think we've got to begin far earlier in our education spectrum than I ever dreamed, even to the middle school level. Thank you, Chairman.
Thank you. Thank you. Thank you, Mr. Comptroller. We have a few caption bills out there, and we've got some ideas. And thank you so much to you and your staff for spending a lot of time on this. And I'm sure we're going to be seeking your assistance before the end of session. So thank you very much. Is there anything else to come before the committee?
Chairman, I just had a logistical question. I know that there'll be some fact-finding trips that will be done over the next couple of weeks by this committee, which I think are extremely beneficial. I know all of us will not be able to attend those, but at some juncture, for those that are kind of watching and following very closely the work of this important committee, Mr. Chairman, what do you anticipate will be a first opportunity for kind of a public meeting and discussion of this committee of some of the ideas that we have heard?
What I anticipate is we have gathered a lot of information, and every week we sift through ideas and information that we've received. We've compiled a list of several different areas, and what I anticipate is this committee getting together. If you have any other ideas, which you may have already given them to my assistant, Linda. If you have not, please do that, because we will get together and sift through all this, come up with recommendations on what we can do this session. So, Chairman.
And, Mr. Chairman, I had gotten this question from a couple of different people. The date of a meeting like that has not yet been set.
No.
Correct?
Right.
But you would anticipate that would be a public meeting. We'll discuss this for any interested parties to be able to
all our meetings are public.
Yes, sir. And I just wanted to put an exclamation point on that for anybody.
Let the sun shine in, right, Mr. Comptroller?
Amen. Thank you, Mr. Chairman.
Chairman Dunn.
Thank you, Mr. Chairman. I've probably made this point before, and I know in our Knox County Task Force I say it time and time again, but I always say we cover a lot of ground, and we talk about the addiction, the treatment, the education early on. But this opiate addiction, remember, this is a drug that is controlled by the government. Every pill that's made, we know exactly how many are made. We know exactly who makes them. We know who prescribes them. We know who fulfills that prescription. It's not like heroin where somebody's making it in some dark corner or somebody who's growing marijuana someplace. And the key will be the physicians. If they will only prescribe the correct amount for the correct rate of time, we solve 90% of this problem. And so I hope as the committee goes, we keep focusing back there. And it might be good if y'all come to Knoxville, we have a lot of doctors who have worked on this, and maybe get with them and say, what is it that we can do to educate doctors and those who refuse to be educated? What is the carrot and what is the stick, and what is the best way to approach to make sure that somebody doesn't give a 30-day supply when 2 days is all that's needed? because people get addicted when there's too many pills floating around out there. So that's if you can solve the prescription, what the doctors write, you'll solve 90% of what we're talking about here.
I agree with you, and thank you for those comments. We are up against a time constraint. As you know, committees are going to be shutting down within the next. So I think what we're going to concentrate on first is any legislation that we can introduce this year, and then there's a lot of work that we can continue doing. But I think our main focus right now is legislation that we can get done, that or issues that require legislation. There are other things we can do without legislation. Any other comments? Thank you. Thank you very much for spending your Thursday with me. And without objection, we're adjourned.